Intravenous therapy, fluid and medication administration. Intravenous access provides direct access to the circulatory system, and this allows for a rapid drug action. We can also achieve precise dosage calculation and flow rates. It avoids pain and tissue irritation from intramuscular or subcutaneous administration or oral drugs that might irritate the gastric mucosa or might be inactivated by gastric juices. The dose can be titrated to achieve a desired therapeutic response. Prescription should include for a continuous infusion the flow rate. We should not have a TKO or a KVO rate because those don't have specific flow rates. In mLs per hour or the specific volume over a specific time frame. The route, the type and amount of solution, any added medications including dosage. For intermittent infusions, we need the route, the solution and medication, and the amount and dosage, and the frequency. Be aware of the fluid types and the expected outcomes, and always verify the compatibility of fluids and/or medications if they're administered in the same site. Incompatibilities can cause precipitates in the fluid or change in the action of the medications. Infusions can be administered continuously or intermittently. Solution containers can be a flexible plastic bag, semi-rigid plastic bottle, glass bottle, or syringe. Again, those glass bottles and semi-rigid containers may require an administration set that has a vent to allow air to enter the container and displace that fluid. The flexible plastic bag has two ports, one for attachment to the administration set spike and one for injection of medications. Never use a marker directly on the bag as the chemical can penetrate and bleed into the solution, contaminating it. Always use a label that contains information per the facility's policy. This is usually the client's name, their room number, any medications added, their identification number, the date and time hung, and the flow rate. A solution container should never hang more than 24 hours because of the risk of bacterial growth. And containers can come in a variety of sizes, from 25 mLs to 1,000 mLs are the most common. Cross-check that solution with the order or a medication administration record, and follow the medication administration rights. Inspect the solution container to make sure it's free of floating particles, that it's not discolored, not expired, not cracked or leaking. Excuse me. And if any issues are discovered, don't use it and return it to the pharmacy because they may be able to receive a credit from the vendor. There's a variety of things that can affect the flow rate of an infusion unless it's controlled by an infusion device. That would include the height of the fluid container over the patient's heart. So the higher the container, the faster the flow rate. The volume of fluid in the container, the greater the volume of fluid in the container, the faster the flow rate. The viscosity of the fluid, how thick is it? The cannula diameter. Fluid is going to infuse slower through a smaller cannula. Venting of the fluid container. If it's not vented, it will not flow appropriately. Position of the extremity. If the tip of the IV catheter is next to or in a joint that bends, such as a wrist or the antecubital space, the flow is going to be significantly affected when that joint is bent. IV medication provides the best therapeutic effect because it's rapid. It can be administered when oral intake is inhibited or prohibited. It can eliminate pain or tissue damage. Risks are once you inject it, you can't take it back. It is immediately metabolized, so risk of too rapid a response. Can be given continuously or intermittently. With intermittent, we consider that to be an IV push or an IV piggyback, and it can be done into a continuous infusion or into an intermittent device, otherwise known as the saline lock. Admixing is the addition of a diluent to a medication or a medication to an IV solution. We usually do that in the pharmacy, but because of the instability of some drugs, it has to be done just prior to administration. And it should be done in as few steps as possible to reduce the risk of contamination. Make sure you limit distractions during preparation, and refer to the pharmacy, drug book, drug label, or manufacturer's direction to make sure that you're using the proper diluent, proper amount, etc. Use this aseptic technique. Remember that a rubber stopper under a vial cap is not considered to be sterile. And draw up the required amount of an appropriate diluent. Don't use pre-filled syringes for that diluent. Inject it into the vial to dissolve. Gently agitate it, but don't shake it. Withdraw the appropriate amount of medication into the syringe and infuse it as an IV push medication or inject it into a 50 or 100 ml bag of compatible fluid for a piggyback infusion. Determine compatibility of medications or fluids that might be infusing in a continuous infusion prior to administration. If it's incompatible, it can cause precipitates or cloudiness. If it is incompatible, you have to flush before and after medication administration. Scrub the port between every flush, medication, or infusion. With IV piggyback, determine that the medication is compatible with the primary infusion. Get your secondary tubing primed. You can do back priming after you connect it to the appropriate port by opening that roller clamp on the primary tubing and secondary tubing, and then lowering the secondary solution container. Close the roller clamp on the secondary tubing when that drip chamber is about half full. Make sure that you put the primary solution container lower than the secondary solution container using the hook that's in the administration set package. With piggyback infusions, connect it to the port closest to the drip chamber after you disinfect that port and infuse at the prescribed rate. With IV push, we never mix two drugs in one syringe. Each has to have its own syringe, but it might be okay if it's an intramuscular injection, just not for IV. If you're administering more than one medication, make sure that you flush with normal saline between medications. And always with IV pushes, inject in the port closest to the client. So, if the client has a continuous infusion going and you're doing an IV push medication, stop the infusion and clamp the tubing just above the port closest to the client. Cleanse that port and attach the saline syringe. Aspirate. Slowly push saline, watching for abnormal signs at the insertion site. Detach the saline syringe and cleanse the port. Then attach the medication syringe and inject the medication at the predetermined rate. Detach the syringe and cleanse the port. Attach a second saline syringe and inject at the medication determined rate. Remember, you still have medication in the tubing and the catheter, so you don't want to just push the saline in after the medication has been injected, or you will be bolusing the client. Then unclamp the tubing and restart the infusion. If you have a locked device, use the same steps that I just described, except unclamp the extension tubing prior to aspirating and flushing. And then with that final saline flush, provide that positive pressure. In other words, you are holding down the plunger of the syringe while you clamp the extension tubing to help prevent the blood backflush into the catheter in the tubing. The flushing solution that's recommended for short peripheral catheters is normal saline. It's also the same for a central venous access device, but you may also be required to use heparin to keep it patent. Your high-risk infusion medications are going to be heparin, thrombolytics, insulin, narcotics, promethazine, potassium. Always double check those medications and your calculations, dosages, infusion rates with a second professional prior to administration. Then, you're going to label the medication, including the client's full name, date, name and amount of IV solution used to dilute the medication, the name and dose of the medication, and the rate of infusion. And then administration. Identify the client with 2 methods. Check their allergies. Be familiar with the medication, such as the risks or vesicant or irritant properties. Explain the procedure. Assess the vascular access device system and function. Assess the medication container for leaks, contamination, and expiration dates. Excuse me. PCA, or patient-controlled analgesia, allows the client to control IV delivery of analgesia. The client will push a button to receive a dose of analgesia. A timing unit on the machine will impose a lockout time between doses and prevents overdosing. The client does not receive any medication during the lockout time, even if the button is pushed. The machine also has a lock to help prevent tampering with dosages, the syringe, etc. It's used most often in postoperative clients or clients that have chronic diseases. And these clients must meet requirements. They have severe, constant, or intermittent pain. They have the ability to understand and comply with instructions, the ability to press the button, and they should not be sedated from other medications. Now, there's some clients that can receive this PCA analgesia, but they do require additional monitoring because there's an increased potential for oversedation. These clients have a history of sleeping disorders, respiratory or cardiac disease, kidney or liver failure. They're older adults, thoracic surgery, lengthy duration of anesthesia during surgery, and morbid obesity. The nurse will always monitor the respiratory rate for 1 full minute, the respiratory quality, sedation level, respiratory noises, routinely with PCA use, in addition to the amount of drug used and their pain level. Advantages of a PCA include no intramuscular analgesia administration, individualized pain relief, decreased time between pain onset and medication administration. The client has a sense of control, and it helps allow for night sleeping and decreased day drowsiness. In addition to these clients often will use a less amount of analgesia when they administer it themselves. So a PC order will require a loading dose, a lockout interval, a maintenance dose if it's a continuous dose, an individual dose if they're just getting boluses, and a maximum amount a client can receive within a specified time frame. And occasionally there will be an order for a bolus dose if the client has breakthrough pain. The client should be the only one to control the button that delivers the analgesia. However, at times the nurse may need to help do that. That may also include an authorized agent-controlled analgesia administrator if a client is unable to do it themselves. And that can be a nurse, a parent, or a caregiver. Double checks should be completed with PCA administration when starting a new PCA pump, changing the dosage or lockout interval, or replacing a filled medication container with a new one. Complications of PCA is respiratory depression, anaphylaxis, nausea, vomiting, constipation, orthostatic hypotension, drug tolerance. Interventions in case of a complication: stop the infusion, notify the healthcare provider, and be prepared to administer oxygen and/or an opioid antagonist. Parenteral nutrition provides necessary nutrients and calories IV when the gastrointestinal tract can't or should not be used. It is customized for each client. Now, LPNs cannot initiate TPN, but they can monitor an infusion. It should be administered through a central line. Conditions that it might be used for would be a client with a debilitating illness over 2 weeks, critical illness, organ failure, deficient or absent oral intake over 7 days, loss of 10% or greater of a pre-illness weight, serum albumin below 3.5, poor tolerance of enteral feedings, chronic vomiting or diarrhea, an inability to sustain weight, or gastrointestinal disorders. Again, the solution is developed individually to meet those clients' needs, but it can contain dextrose, proteins, electrolytes, vitamins, trace elements, water, and/or lipids. Risks are infection, hyperglycemia, and hypokalemia. When we give TPN, make sure that you warm the solution for about an hour ahead of time. Always check your order, determine the patency of the IV site, use strict aseptic technique, change the solution and administration set at least every 24 hours, monitor vital signs at initiation and every 4 to 8 hours, monitor your glucose levels routinely. These clients may require temporary insulin. Monitor the client's overall status, and when discontinuing, we should wean it over 24 hours rather than discontinuing all at once. The solution container and administration set, don't forget, need to be changed at least every 24 hours. And vesicants are drugs that are especially toxic to subcutaneous tissues. In other words, if these drugs infiltrate into the tissue, they can harm the subcutaneous tissue. The physician should be notified in the event of an infiltration. If a vesicant is infused in a peripheral line, that site has to be monitored every 5 to 10 minutes. To reduce the risk of infiltration, the largest vein available should be used. The smallest appropriate cannula should be used. Ensure that cannula placement is patent prior to the administration of a vesicant, and flush the cannula after a vesicant is administered. Common vesicants that we do administer would be vasopressors, potassium chloride, and anti-neoplastic agents.